Good evening, everyone, and welcome back to GB School of Neuro Rehab and Aquatic Therapies live session. So, in our last lecture, we learned a lot of things regarding neuroplasticity, the factors that affect it, what should be the intensity, the repetitions, and everything. So, in today's lecture, we'll actually learn about how we should plan our clinical session, what kind of feedback we can give to the patient, what kind of external devices we can use to enhance treatment. So I hand over the mic to Gajanan sir today to take over the lecture.
Thank you, Manasa.
Welcome, sir.
Can you see the screen properly?
Yes, sir.
Okay. So, good evening, everyone. Today we are going to discuss with our previous lecture content, which was clinical application of neuroplasticity. This is the second part of the previous lecture, and we'll add more details in the previous lecture's content. So today we are going to touch about how do we design the exercise program so that it will improve their performance, and it will use neuroplasticity and enhance recovery more commonly in our patient. So the first question is commonly which been used, or it's commonly been raised in our brain, is that how do we design an exercise program? Usually we do not use the word design with the exercise prescription, like commonly we use what is the exercise prescription, but I use the word called as designing of the exercises program, because this design has to be very specific to the needs of the patient, his goal, our goal, and his role in the community. So I use the word called as designing of the exercise program. So how do we should design the exercise program? What are the points should be considered? So in designing, we should include that the training should happen in a natural environmental context. So we try to keep the environment as natural as possible. Frequent movement repetition should be included. Training load should be the patient and goal tailored. So the training load has to be, or the intensity has to be tailored according to the patient, and it also according to the goal what was accepted by the patient and the therapist. And it should have differentiation in the intensity by the means of strength, endurance, and coordination. So there should be permutation and combination of these should be allowed in the training load. Exercise variability should be offered. So whenever we are designing, there should be different levels of variability. You can say low level, mid level, high level, or there can be multiple levels of variability that has to be organized in the exercise program when you plan from the beginning. Distributed versus random practice should be included. So here you can have a random practice or distribution part practice like this. There should be combinations allowed in the whole exercise program. And while we are designing this exercise program, most of the patient they do very good in initial phase of rehabilitation and they participate very well. But within few days they get bored, and the motivation aspect get lost, and they start getting bored. So to cover this problem, what should be included in the designing of the exercise? The training should be including some fun and gaming, and it has to be engaging for the patient. Sometimes we design exercises which are fun and gaming, but if it is not engaging, then also the patient gives up very fast. When I say engaging, as in the previous slide we discussed, if there are different levels of variability, and the person's is more engaged in winning the next level, like that, it is more effective. Like suppose you are just playing a football and you are just telling him to kick the ball while he is balancing. Kicking a ball is just a simple exercise. It is fun and it is gaming. But how do we engage and increase the variability? That has to be thought process. That should be thought from the beginning. Now he is able to kick. So what should I do next? So like this, you have to plan and keep engaging. the more you keep the person engaged, he will be more motivated and he will participate more and will show good improvement. Active role of patient in rehabilitation should be estimated by. To make them engaged and to make them active, what are some points should be included in the therapist independence as on the system's use. So the more the therapist is independent of the system itself should be designed in a such a way, or the exercise program should be designed in a such a way that it does not require too much of involvement of the therapist. And this is how it will motivate the person very well, and it can do the permutation combination very easily. Individual goal setting that is guided to be realistic. So whenever you are setting a goal, whenever you are designing a game or a task, if the goal is too much high and it is impossible for the person to achieve the goal, then also the person doesn't get motivated and they lose the interest very fast. So you need to design the goal which has to be realistic but still challenging. And while being challenging, he should be still be engaged in the exercise program. So self-control on delivery of exercise instruction. Now, while we are doing this program design, we have a very common habit of giving too much of instruction. Like suppose we are teaching somebody to hip flexion, we keep saying flex, 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 extend, 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 flex, flex, flex. For every repetition, we are giving instruction, or if he's doing some activity, we can continuously give him instruction. So we have to have a self-control on giving of instruction or the feedback that should be guided in the motor learning. So do not give too much of instruction also, and do not give too much of feedback in the exercise program. Let the person do some trial, let him fail, and you give instruction and feedback whenever it is required or appropriate. Control in training protocol has to be based on the exercise and exercise material. So whenever you are designing exercise, the control parameter should be how you are designing the exercise, or what are the material, or what is the setup. So by just changing the setup of the exercise, can you change a little bit in the level of exercise or engagement of the exercise? Can you make challenging or less challenging? All this point has to be taken into account when you are trying to design the program. So while as we discussed that we give too much of instructions and then the feedback. So what are the points should be taken into account while we are giving a feedback on exercise performance? So the typical types of feedback can be analytical or global general feedback, like you give them a video, or verbal feedback like you did good job, or it was overall like this, or you can create a avatar by using technology, or you can use a kinematic model, or it can be analytical feedback like it can be EMG guided feedback, or positioning versus time, what was his position of the joint, angles or velocity or jerk, movement disorder, movement distance or movement completion time or movement direction. All this can be the relation of what was his relation of the position with the time. Like suppose in walking of the gait, in walking, you are doing a gait analysis and you are telling him in what phase you did abnormal pattern of movement and what was your position, and how much time you took to do that. Or like somebody is taking more time on affected side than the unaffected side, or suppose he is doing upper limb exercises, you can give a feedback like in the initial range you are very good and the speed was better, but the moment you gone for a overhead range, the speed was slow and the positioning was bad. Like this you can use, or you can use some pressure platforms also to give a feedback. There can be extrinsic feedback also, can be given intrinsic feedback, which is happens in our body, and the person gets automatic intrinsic feedback, but we can enhance the feedback by extrinsic feedback. And there are two major types of feedback. One is the knowledge of result and knowledge of performance. So knowledge of result can be non-quantitative or quantitative. So in quantitative, this is BW is stand for bandwidth feedback. So based on the bandwidth, this is electronic feedback. We are talking about technology guided feedback. So here the non-qualitative will be just bandwidth, like this is the range you moved or not moved, or quantitative can be average band feedback. What was the total performance of the whole walking? Like suppose we are doing a gait analysis, if you get analysis, you get a general feedback overall. The gait was normal or abnormal, or what was the common gait deviation. And there can be summary feedback where you give more details of what range they worked, what range did not work, and how the kinematics change. All this can be used to give feedback. Knowledge of performance can be qualitative, and then can be two types of knowledge of performance feedback you can give. One could be concurrent feedback, or could be terminal feedback. So like concurrent feedback, like while he is doing the activity, you are continuously giving him, okay, move on the right side or move on the left side, you move your hand upward or leg downward. Like this, you are giving continuously concurrent feedback. Or you allow the person to do whatever the task is being told to him, and by the end of the session, you give him terminal feedback, like in this particular angle or in this movement you were away from normal deviation, and whereas in the other area you were better able to perform in a desired action and desired range. Like this, you can give a terminal feedback or concurrent feedback. There can be two options. There can be prescriptive feedback or descriptive feedback. Most commonly happens is a prescriptive feedback, like you conclude, okay, you are abnormal, you are not doing good in that area or that particular activity, and you conclude that you are not doing this and you should do this. So it's kind of problem solving directly done by the therapist, which is the direct prescription you are giving. There can be descriptive feedback. You can tell him, this is what you were supposed to do and this is what you did. So what do you think? This is right or wrong? What do you think? What can be done for this type of abnormal deviation? And you just give a description like this. This is expected. This is what you are doing. Now let him conclude if it is the right type of activity or wrong type of activity, or he will say that, oh, this is what happened with me and that is why I did this permutation combination, or that is why I did some alteration in my movement. And so you need to look at this prescriptive and descriptive. Do not try to be more prescriptive from the beginning only, like you conclude this is what you did wrong and this is you should be doing, and this is the correction required. The more you are descriptive, the patients will get involved in your feedback more. He will also understand what is going wrong and how it is going wrong. Like let me give you example. You must have all of you must have seen the Dance India dance program. In that, Terence was giving a lot of descriptive feedback. Like he used to say, oh, this is the position, you were not able to do this angle, you did very fast or very slow. So Terence was able to give more details to the participant, and then the participants will could conclude or do the modification in particular position and particular activity or particular dance. Whereas prescriptive feedback, like overall dance was good, but I think you could have done better, and the movements were not very acceptable. Like that is also not good. Same in our patients also. Whenever you are, suppose we'll take an example of gait training, and you are teaching him to walk. Instead of saying that you did good or bad, or you did too much of circumduction, or you did too much of flexion, you can say descriptive, I wanted you to flex around 30 degree or 20 degree, but you could only flex for 10 degree, or less flexion was there, or more extension was there, and this is what you could have done. Like this could be a better way to explain, and more detail and description you give to the patient. The patient understands the intricacies of the activity, and he will participate better, and next time there is less occurrence of that abnormal deviation. Now we need to understand two important things. One is knowledge of result and knowledge of performance. Very frequently in therapeutic practice, we emphasize too much on knowledge of performance. Like from the beginning only, we start giving instruction that your flexion movement was not good, or you did too much of flexion or extension in upper limb or lower limb, and you give a lot of details about the performance. and we forget whatever the task was given and did he completed the task or not. Usually I do what I do in my practice, that I don't focus too much on knowledge of performance in the beginning. In the initial stages of training, I only focuses on knowledge of result. So you give them a particular task, and at the end of the task you just analyze, did he completed the task or not. Suppose example again of get training on walking, you told him that you have to move from point A to point B without a walker or without a cane, or with a walker or without with a cane. And he moves from one place to another and he completes the distance. So first question should be that did he completed that total distance or not. Okay, he completed. Then how much time it was taken, that should be taken into account, and then you give a summary on that you did complete the task or did not complete the task. Or say sit to stand you are doing, and you are teaching somebody to do sit to stand, and you told him to stand from a bed to a complete erect posture. And by standing to the erect posture, the person will understand, oh, I did completed my task and I could stand completely independent without support. So the knowledge of result is so much important that the patient understand what is the end result, what is the end posture, what is the end activity I achieve. And it will classify them is in the two category, like did they complete it or not complete, did they succeeded or not succeeded. So always remember, as a human behavior, we only tend to repeat behavior which are highly appreciated, and we tend to repeat behavior which we succeed. Like suppose if you are frequently failing, like every time the person is trying to do and he's failing, or he doesn't know what is failure or success also, then it is very difficult for the person to keep engaged and continue with the exercise. Like if you don't know what is if the patient doesn't know what is expected out of him in the whole activity, like you told him to do the walking or you told him to do the sit to stand, and he doesn't know what exactly the kind of end result posture or end result alignment you are expecting. And because they don't know, they can't complete. So knowledge of result is always better. Let them understand what is the end result, what is the total expected result you are expecting out of him. And once he get that feedback, then he can step backward, or he can do the backward calculation. Oh, this is what I am supposed to do. So based on that, then he will do the backward calculation. These things I am supposed to achieve, and then he will add up all the activity. And always remember, as humans we always like to win. And if you explain somebody what is the knowledge of result, and this is how I can win or lose, and if he keeps repeating the activities, and if he wins more frequently, he will repeat the behavior. But if you don't know what is the end result or what is the total knowledge of result of the activity is explained to him, he never understand, is he failing or is he passing. And because of that, most of the patients in our therapeutic environment, they lose. Like imagine you are training somebody on a ball and you are doing some permutation combination handling, and you are so much engaged and you are doing something on the patient, and the patient actually doesn't know what he's supposed to do and what he's not supposed to do. He's just reacting to your weight shifts. And because there is no information for him to do on what is expected, there is no learning, there is no neuroplasticity occurring. It is just what is a subcortical plasticity might be occurring at the non-cognitive level. If you move someone like this, there will be some reaction in other area. So it's always better you explain what is the knowledge of result to the patient, and once you explain that, the patient will understand what to do, and the participation will be more. Once you are sure that the person is doing good activity and he's able to get the knowledge of result, and or he is completing the whole task, then you can go on giving feedback about knowledge of performance, and then give more details about what should be added in the original expected exercise program. Now as I said, to keep them engaged, there should be progression component also. So how do you do the progression of the exercise is very, very important. So the fading of frequency schedule, like whenever you are giving a feedback, the feedback has to be, there has to be fading of frequency schedule, in the sense how frequently you are giving the feedback. Like in the beginning you might be giving continuous feedback, then you are giving at least after 5 repetition, 10 repetition, 20 repetition, like that. Or you are giving at the end of whole session feedback, or you are giving after 2 days, 3 days. Like this, you can change the length of the feedback, or you can give a short summary in the beginning, and then you can give a long detailed summary. So the frequency of the feedback and timing should be changed. And we should start from the prescriptive feedback to the descriptive feedback in the beginning, because as I said, the knowledge of result is so much important in the beginning. So in the beginning, you can tell him, okay, this is what you were supposed to expected, and this is what you achieved. So did you pass or fail? So and you say, okay, you did not pass in the previous session, so I want you to do something differently like this time. And once you do that, then you can give a descriptive feedback. Okay, you this time you could do better, but these are the details you are missing in the particular task, and that way you can give a descriptive feedback. So from general feedback to the sequencing or some specific feedback, like general movement happened better or not expected, as not expected, or you want a specific range of movement, like mid range you did better, whereas outer range you were not able to do it. Or the force application in the beginning you did not apply too much force, but in the mid range you could apply much better force. So you can give this kind of specific feedback to the patient as well. From simple to more complex feedback. So in the beginning you can have a very simple feedback, and then you can go to more cognitive level, based on the patient's cognition level. You can keep changing these feedbacks. So empty time slots for performance evaluation before and after giving feedback has to be given. So what happens once you give a feedback and suddenly you start getting him engaged in the exercise program. So after you give a more detailed descriptive feedback, there should be some slot given for him to self-analyze and do the problem solving. Let him understand the whole feedback concept, and he will do self-evaluation, and then he can practice. So there has to be some empty slots for performance evaluation before and after giving feedback, and after that also you can do the performance evaluation again. Guided self-control on timing of delivery feedback. As I said, you should have a self-control on timing of delivery feedback, and there should be a guided mechanism. Like you should have a schedule. Like usually in our setup, we have a schedule program. Like every 1 week or every 2 weeks, we are given to give you overall feedback of the performance. Are you improving or not improving? So like this also, you can have a guided control on timing of delivery feedback, or in the whole session also you can say that now 10 minutes you can do whatever you want. After 10 minutes I will give you some feedback about what is your performance. So this is how you can do the permutation combination based on your patient's need and his understanding. Feedback on error or correct performance. Usually whenever we talk about the feedback, very commonly we talk about what are the problems or what are the errors or what mistake the patient has done during the activity. But while you are giving error feedback or mistake feedback, you should also give what things he did rightly, what are the things his performance much better. And you can use a concept called sandwich feedback. You always start with the correct performance feedback, then mistake feedback, and then again correct performance feedback. So you start with good thing and you end with the good thing. So the person always remember what is good he did in the exercise program, and that is how he will get motivated to participate in the overall exercises. What are the possible adaptations after your training? So if the training and feedback and exercise program was good, there will be two adaptation happening, and the client is trying and failing out of the failing but accepting. Every time he is trying to cope with the challenge. Sometimes he fails, sometimes he doesn't achieve what is expected, and sometimes he achieves what is expected. But because he is more involved, he is more engaged, and he will keep trying. Like this is what happens with our video games. Like in the beginning we succeed very fast. Like you take up Candy Crush game. In the beginning we succeed very fast, and we move do the Candy Crush level very fast. But once we go upward, we keep failing, and we require some additional there are additional features which has been added in the Candy Crush program, and these features then help you to succeed. And sometimes we don't succeed for 2 to 3 days also, but because it is challenging and engaging, we keep doing that. and this will allow us for growth and acceptance for the change. So this is a good combination of failure and success, and more involvement, more engagement in the exercise program. So there is a good acceptance by the patient, and then they participate in their growth, and there is a this acceptance of the challenges will help them to get more of functional flexibility and enjoyment in the life. Because our daily environment or the real life environment is not always helpful, or not every time we succeed in all the activities. So there is always a combination of chances of failure and success in the real life environment. So we are actually indirectly preparing for them for the real life environment. And if some adaptation are superficial and looks good and sounds good, but is not dealing with the change, like suppose we always give them patient some instruction to do some activity. Like suppose you are teaching very commonly in our regular therapy rehab, like how to do supine to sit, or how to do sit to stand, and how to walk. And in the particular training, they understand what are your instructions, they copy paste for a few times, and they can easily do that. But the moment they go home, they go back to their real life situations, or they always follow the previous pattern. Uh, because they were not too much engaged in your instruction, they were not engaged in problem solving, you only concluded you did good or bad. And they were not getting a lot of descriptive feedback where they did the problem solving. So these kind of changes are superficial, and in long run that becomes maladaptation, and then the disability gets more prominent, and our patient doesn't learn from this. So what should be the ideal rehabilitation environment, and what factors should be considered while you are planning the ideal rehabilitation environment? So as we know, the plasticity occurs at any age, internally and externally driven. So we need to understand while we are designing the exercise program, what type of plastic changes we want to stimulate. We want internal driven plastic changes should be, or external driven. Usually, I prefer in the beginning always external driven plastic changes are more easy to be stimulated and more easy to do to the permutation combination, because we can control that. Because the internal plastic changes or internal mechanisms of neuroplasticity which occurs in the patient's system, we cannot control that very much, especially in neurological population. But external factors are very easy to control and do the modification, and this will improve the plasticity very well. And also it has to be age appropriate. Generalization to the extent that behaviors are similar. While we are designing the exercise program, the environment has to be real life, or actually more realistic to the original life. Like suppose you design environment or a specific design, like suppose you take a very high advanced equipment, like a balance trainer, and you train him on the balance trainer, and he's doing excellent job on the balance trainer. But when he comes on real life situation, like balancing on the ground, may not be showing good transfer of learning of that balance training. Instead of that, if you teach him some activities where he's standing on the level ground, and you are teaching him real life balancing activities, and you use ball catch and throw, or while he's walking and then ball catch throw, or he's lifting some bags and walking and then balancing, or he's pulling some cart and then walking, like this, there'll be a good transfer of learning. Like I use very commonly to do the balance training, like lift up buckets, fill up of water and then walk, or you can lift a bag up in one hand and then walk, or lift up bucket in one hand which is filled with water, which will cause destabilizing forces on the body, and then he has to walk. Like this you can do real life environmental modification. Or you can take him outdoor environment where there is uneven surface, or soft surface, hard surface. Like in the context of soft surface, hard surface, very commonly therapists teach the patient to walk on the foam. We have thermats which are given, or we use soft mat and we make them walk on the soft mat. Instead of that, why don't you take them on the road and make them walk on uneven surface, or why don't you take them walk on out and make him walk in the sand, or even walking on the grass, which is a high height grass, which acts like a soft environment. But and these are more real life examples, and there is a more generalizability to this type of task than teaching somebody walk on foam and then balancing on the foam, and then you are expecting there should be a good transform of the balance training in real life. That doesn't occur because the person doesn't remember that the walking on foam is similar like walking on the grass, or walking on a hurdle crossing. Walking with hurdle crossing given in the therapeutic department is similar like crossing the bar, or crossing a pavement, or crossing some stones in the path. So the more you go to the real life environment, there is a good generalizability and more learning. And there has to be frequency of repetition required. Like suppose you use a soft mat to walk. A soft mat can be 1 meter, 10 meter maximum, and then walking on the same thing again you have to keep repeating, and this repetition get bored after few days, or after few repetition. Instead of that, if you take him out in the garden, and there is a huge lawn, so now here the walkway can be 100-meter also, and he can take more rounds in the grass, and it will not be boring. So there will be more opportunity for frequency of repetition also. And there has to be meaning of similar to the patient. As I said, the meaning of foam walking, or walking on a foam mat, has a different meaning compared to walking on a grass, which is the real life environment, which has a real life solution, or walking on the uneven surfaces on the road, or walking by the side of road, which is footpaths with a lot of hurdles are there, which has a real life meaning to him. And this is how he can relate to that very frequently, and there will be a good neuroplasticity there. Opportunity for interaction with enriched environment, like all these examples which I gave you, it has a lot of enriched environment. Also, you try to keep your environment in the department as enriched. There is always a limitation, because we have a limited space in our therapeutic department or rehabilitation department. You will be able to do some enriched environment, but it will have a limitation. And if you don't have a possibility of going outdoor, or using real life situation, you can do enriched environment. Or if that doesn't happen, then we can use virtual reality environment, which can give a lot of interaction and permutation combination. While you are designing, we should also consider what is the age at the injury, and age of the injury. So like late injuries, or injuries which occurs in old age people, has a different type of rehabilitation program, and requires different permutation combination compared to the young population. And also a chronic injury will have a less flexibility, and there are a lot of adaptive changes. So our exercise program has to cater, or should be designed in such a way to solve the previous maladaptive postures and maladaptive behaviors, and unlearning first, then focusing on learning. And in that also we have to look at intervention timing, like acute phase and chronic phase. So in chronic phase, we have to solve the secondary problems or maladaptive behavior a lot, and we require more intensive training and more repetition. Whereas in acute case, we might not require so much of intensive training and no high intensity, because it is a new learning behavior, and we don't have to do a lot of unlearning types of training. So few people in the beginning can learn very faster, and there is also a natural process of neuroplasticity which occurs from first week to around 6 months. So if we augment that natural recovery and natural neuroplasticity along with our experience dependent or exercise dependent neuroplasticity, there is a good overlap, and we can get better recovery compared to the chronic patient. Compared to this, the chronic patient, they already got the natural recovery which has happened, and the natural recovery along with there are adaptive neuroplasticity or maladaptive neuroplasticity which occurred. We have to overcome that and then create a new neuroplasticity. So this is how this can affect our training program. Also, pre-injury skills are very important. Like the people who are more engaged in sports or physical fitness show better recovery, and can tolerate high intensity of training, or somebody has a high speed walking or a balance training type of activity in their real life. Like somebody is a dancer which has a high balanced training activities from the beginning. So ability to train them balance on different environment is more easy and more effective compared to somebody who is sedentary, not engaged in so much of real life activities which requires a lot of balance and speed. In that case, training them will be more difficult. So the pre-injury skills also has to be taken into account, and based on that you can design the exercise. So sensitivity of the recovered system to drug and other effect. So depends on what systems which are recovered to the drugs and other effects. Based on that, we can use that sensitivity to supplement or augment our recovery, or it can used for causing hurdles. Like suppose we want to reduce some maladaptive behavior, we can use this type of recovered mechanisms or sensitivity to obliterate the natural occurrence of maladaptive behavior. Secondary injuries, coma, and various injury mechanisms. Like whenever we are doing high intensity training, there is high chances of secondary injury. Like very commonly when we do a lot of high intensity training in our therapeutic department, a lot of patients complain with knee pain or back pain, or there can be some strains on some ligament, which can also again obliterate our next month rehabilitation. This is very commonly happens in hemiplegic and paraplegic. Whenever we are doing too much of intensive training of walking, they start getting pain in the shoulder or the hand or elbow, and again the exercise program gets limited. Or somebody has already a coma or a low functioning cognitive structure or low functioning cognitive ability, it can affect the recovery and learning. Or there are other various injuries which happens during the session or outside the session, or they had a fall at home or during transfer, that can also affect our rehabilitation program. And we should also think about the surgical intention and surgical intervention given in initial period, or in between our rehabilitation. If there are some surgical interventions are being done, then we need to modify our program according to that. So in the end, we are going to discuss role of virtual reality training and robotics. As we were trying to discuss that, if you are trying to get the environment more enriched, you can use real life situation or do modification in the rehab department, or you can create a virtual training session. So nowadays there are very frequently these virtual reality training equipments are very commonly available. Most of these virtual equipments are being used for gamings. Like there is Xbox 360 Kinect, there is a PlayStation, Play Store, not a Play Store. I think Sony's PlayStation, and then Nintendo. Like these equipments, they are very well available in the market, and they are not very costly. So you can use that in rehab. Like here, I'm trying to use Xbox for standing balance in a paraplegic, and I used here harness to support her, and she's standing with the KFO. So we can use this type of virtual reality environment also. So while we are using the virtual reality environment, they are using the principles of neuroplasticity and motor learning. And the beauty with this that we can do the task variations very commonly, and there are multiple repetition in different movement directions, and there are always goals in the game. So it is always meaningful to the user, and there are adaptive routines, and clinicians set difficulty. Like we can set the difficulty you want to play with the beginners level or medium level or high level, and there are a lot of variations are available in the game. So these variations also gives continuous challenge and keep the person engaging. And the games always gives you scores while you are playing, and at the end of the session also. So this will tell you, are you going in the right direction, or you are winning or losing. And there are multi-sensory feedback which are happening, like in all these games. Not only they give you the movement feedback, but there is always some audience which is cheering you, and there is some comments are going on, or at the end of the session they clap for you. Like this, these are very beautifully designed program, and they always give you knowledge of result and knowledge of performance during the session and after the session also. So this knowledge of performance also is very important. Like in some of the Xbox, like in Xbox 360 Kinect, After the session is over, they give you replay of your exercises, and you will understand how did you move during that session and what common mistakes you have done. So what are the advantages of this virtual reality program? The first thing is, like, I think more than the anything which is more important is the motivation and engagement. There is very commonly patients get demotivated in the routine program, or they get used to our exercise program. It is same routine, and they get very bored due to our exercises routinely happening. But these virtual reality programs, they are very highly engaging, and there is too much of variability, and there is a knowledge of result very commonly being told to them. So the patients are highly motivated to participate in this virtual reality program. And there is too much of adaptability and variability based on patient baseline. Like somebody who's got poor control or not good balance, then you can reduce the computer level to the basic level or beginner level, and then if they start doing better, then you can set the level at the medium level. Then you can set the level at the higher level of competency. So this has very good adaptability and variability. Transparency data surveys. Now, suppose I am giving somebody some exercise, and then it is my interpretation of the exercise. Is he doing good performance or bad performance, or if I know what was the performance last week, so I always rate the person based on last week's performance. Like I wanted to show his improvement, then I might change little bit data. But in the real life virtual reality training, it is already always transparent. There is no there is no variability, personal variability or a bias can be happening there. So it has always transparent data storage. So this give you realistic non-biased data. And most of these games can be played online, so you can have online remote data access also, and you can send this data to their caregivers or the family members also, and they can also understand how was the performance in previous session or in today's session. And it has a very good economic of sales, because it is a one-time investment. You don't need to keep investing. There is no added cost, and it is very economical. Like the first investment only you have to do, whereas in our day-to-day activity there are some associated cost which can be applicable for maintenance, but here there is a less maintenance cost also. And in the same game you can use around 1 patient, 2 patient, 10 patient, and even if you do use that equipment for a whole day, it doesn't get tired, and it is highly economical. And because of all this, it also reduces the overall medical cost. The beauty is that this type of virtual reality training and robotics, they give a lot of repetition without the computer getting tired. Instead of that, if I as a therapist, I wanted to do a lot of permutation combination, either I get bored or I get tired, and then the variability goes down. But the computer doesn't get tired, and the variability doesn't go down. They keep challenging, and they keep adapting based on how much you want to push the computer's level, and then it will also push the patient's level of adaptation. So how do we apply this robotics in rehabilitation? Robot will allow the patient to achieve a task. What is robotics doing with us? Like if somebody has a weakness or inability to do the act, the robot will assist the person in doing the desired task and completion of task. So here again you can understand, in the beginning the robot always focus on knowledge of result, and once you do that, then slowly the robot can also assist in the knowledge of performance and improving the skill or quality of the task. With this robotics, that the repetition is very easy, and it is goal oriented practice based on what is the task given. The repeat always, the computer always or robot always gives the repetitive goal oriented practice. A task can be adjusted to provide success at the limit of performance. So if the person is not getting successful, the robot will adjust the limit of performance and reduce the limit of performance, and then he will succeed. So robotics has this beauty that at the end of the session, the person always wins, and you will always get the knowledge of result. Motivating and very variable. So because we always get the knowledge of result, and the limit can be get adjusted by the computer or robot by itself. It is very much motivating for the patient because the person is always trying to complete the task with the help of a robot, and the computer or robot can do a lot of variations also very easily, and it allows intensive and safe training in the conjugation with you can do this robotic training with along with CIMT for shaping behavior, and could incorporate VR and interaction with computer games. So if we use we take an example of CIMT, like CIMT advises us to give 6 hours of intensive task specific training by the therapist in real life active environment. If you are doing daily 6 hours of training, either you get tired or the patient will get tired, and the variability goes down. But because the robot is assisting here for doing long hours of training, the therapist doesn't get tired, and you can treat multiple patients at a time if you have got multiple robotics also there. So this is how it has a flexibility of doing assisted activity. Like also we will take example of body weight support treadmill training. Body weight support treadmill training, in that we passively keep the patient's leg forward on the treadmill, and we assist him doing a stepping exercise. But in a whole day, as a therapist, we get tired, or we might not be able to do at the same intensity or same frequency for around 20 minutes, but the robot will do that without getting tired, and every time it will have the same quality of maintenance. So it substitutes our energy expenditure very easily, and that is why robotics is good in that sense. But it does not mean that we have to completely depend on robotics. If you have manpower more, and if you have flexibility to do the assisted activity without robots, you can do that also. So it is your choice how do you use the flexibility of robots and manpower. So nowadays the robotics is developing very fast. There are a lot of upper limb assisted robotics which are getting changed, and these are the lower limb guided robotics which are happening. And this is how the evolution of robotics happened. There was a big extinction of the robotic arms in the beginning, and then this kept on changing to going to exoskeleton types of robotics which can be moved with the hand, and the person doesn't have to get fixed to one single point. Like in lower limb, there was actually hip knee flexion kind of CPM type of movement which were happening in the beginning. Then this shifted to body weight supported treadmill training, where the robots helping you to step. Then exoskeleton is coming into picture now. The exoskeleton by itself is helping you to do the ambulation and giving you more repetition. So this is how the robots are getting evolved to give more repetition without getting tired. So what are the major advantages of robotics? The best advantage is like producing repetitive and high quality movement without getting tired, having precise quantification of movement related parameters. So once you did that repetitive measure, you'll always have quantitative movement related parameters, like throughout the work training, when you did better, or when the performance deteriorated, when it was increased or when it was improved. That data can be analyzed and stored, providing specific feedback to the patient, allowing them to enhance their movement, because it gives so much details of parameters of the movement at different phases and different interval. This will give a specific feedback to the patient, and like suppose in walking his flexion parameters were not good, so he can focus more on hip knee flexion, or ankle parameters were not good, or weight bearing was not good, or weight shifting was not good. Accordingly, he will get a very specific feedback by the robotics, and then the patient can work on that. Recording performance and related information. So as we have said that it is very easy to record all the performance parameters, and then we can analyze this information for further modification. And it is providing good man-machine interaction to measure patient progress. So there is a combination of man-guided outcome measure as well as the machine-guided outcome measure and treatment. So it helps us in planning our progress much better. So in oral lecture, we understood that plasticity of brain serves to support learning, and by utilizing these inherent capabilities, therapist and clinician can enhance recovery from brain injury by applying knowledge of these principles of plasticity directed to the treatment. So we can use these concepts, this knowledge about human behavior, human learning, human neuroplasticity of the brain, and role of environment and experience. All this knowledge can be applied in terms of learning and recovery, and modifying the brain with injury. So I suggest we should use this combination of different aspects of neuroplasticity, learning and recovery, and then plan our exercise designing, or an exercise prescription of the exercise program. So thank you very much. This is the end of today's session. If you like our lecture, and if you want to understand neurorehab better, and you want to make neurorehab simple, then you can keep attending our lectures, which are always on Thursdays at 8 p.m. These are the lectures on neurorehab, and on Saturdays, not 6 p.m., 8 p.m. we have lectures on gait and biomechanics. So this Saturday we are going to talk about what are the causes of circumduction of circumduction gait, and how do you manage circumduction gait in hemiplegic. So you can join us on this Saturday around 8 p.m. For causes and management of circumduction gait in hemiplegics. So thank you very much. If you like our lecture, please subscribe and press the bell icon.
Thank
Hi,
you, sir,
Mansa.
for that very informative lecture. And I think it was really great, and so much information regarding every small thing, feedback to how you should give, when you should give, how many times you should give, the type of feedback. And I think I really like that analogy between Candy Crush and this, how the patient should always win in the beginning so they get more confidence. Very nice way, easy way to understand. Thank you for that example. And if anyone would like to ask any questions, please put them up in the live chat section so that I can answer.
I think there are no questions today.
So there are some questions coming up.
Okay.
This is by Ragini. If the person is in coma, then what kind of exercises should be given so that neuroplasticity will occur?
See, the principle always remains same. If you are in coma or without the coma, you should always design real life exercise. Like when I treat patients with coma, I assume that the patient is able to understand my command and able to understand and get the experience of the mobility and the positioning and shifting. So let me give you an example. How do I treat a case of comatose patient? Assuming that the coma stage is around 3 to 7 on GSS, what is that scale? Glasgow coma scale of on the scale Glasgow coma scale 3 to 7, and he is not able to communicate very well. So what I usually do, I teach them real life activity, like rolling is always required. So I do the assisted rolling on either side, and then while I'm doing assisted rolling, I'm also talking to the person that I'm going to take you on the right side and left side. Please keep your hand forward, keep your leg forward. The way we talk to a normal person, what are the instructions given for rolling, and then I make him supine to sit, and supine to sit on right side and left side. Like this, I keep shifting. So what happens? These are some of the movements or the motor programs are already fed in the brain. By giving these repetitive multisensory stimuli, like there is a sensory stimuli happening from the vestibular apparatus, there will be a proprioceptive feedback from multiple joints and skin. These all the multisensory stimuli getting bombarded on antennal cells as well as on the cognitive level, and it will cause the bombarding on the brain, and the person who is sleeping, it will cause stimulation of the brain. This will help you to doing the coma stimulation also, and because these mechanical reaction are always there at the subcortical layer. When you say coma, A coma does only mean that the person is not cognitively involved, but that does not mean that his subcortical reactions are not available. All the subcortical reactions and postural adjustment or balancing strategies are always there. Like you put a comatose patient in sitting and just push him sideways, and you'll always see there will be some reaction, writing reaction or elbow extension or some flexion extension of lower limb will happen automatically, because these are the postural reactions which are occurring at the subcortical level. Like suppose you are doing a handling in a patient with hemiplegia or a baby uh, on the ball. You make him sit on the ball and you try to do the weight shift on this side and the patient rides on the other side. Basically, you are trying to do this as a writing reaction to be stimulated in the patient. So suppose you shift him this side, so the person will correct either this side or this side. So this is how we actually naturally do on the normal patient. So similarly, these reactions are also available at the subcortical level. The only thing in this is that you have to wait for the reaction. You have to give more time, and the range of shift has to be modified based on how does it work. So like whenever you work, usually we go in the lateral plane and we give weight shifts in the lateral plane. When I work, I don't work in the lateral plane in the beginning because it has too much of instability on either side. So I work in the frontal plane. So I let them move in the under forward direction. Like I make him sit, and then I just give a shift from trunk to the backward direction, and then the moment you give backward direction, the body tries to react somehow. Or if backward is not good, you just shift them forward direction, or you tilt the pelvis anteriorly, the body will go into extension. And this is happening in a very short, subtle range. This short shifting is very important, because if you give too much of weight shift forward or backward, the reaction may not occur sometime, and give time for the body to react. So again, neuroplasticity is continuously occurring at the subcortical level. Only problem here is that the person doesn't learn the behavior because he's not actively involved in the process of learning. But subcortical motor programming, subcortical motor control, or subcortical postural reactions is being trained automatically at the lower level. So please keep doing the same protocols what you think is right. Only expect that the patient will not learn. Tomorrow again you have to start at the same level of the activity. His performance will be better, but there will be no carry forward of the learning of the trained behavior. So in the beginning, all of us can focus on body writing reactions or postural reactions, and stimulate this. And the more you stimulate these reactions, you will activate the spinal postural reflexes as well as the brainstem reflexes. And these reflexes, this motor, sensory motor interaction will give a lot of multisensory stimuli to the brain, and the person will become slowly more cognitively aware. Like you must have seen in coma stimulation program, people use a lot of sensory feedbacks. Like you use smell, taste, or audio or visual, but you don't use so much of somatosensory feedback. I prefer a lot of somatosensory feedback and handling a lot along with audio visual feedback, because just giving non-specific sensory feedback, like you are using a lot of different types of smell or audio, it doesn't make sense. But if I'm teaching somebody dancing, like I'm shifting and I'm moving with the steps of there is a music of some dance. So let us say we have put on a song called as Mallari Mallari. So in Mallari Mallari we are moving like this, and I am also moving him, the patient, like this. So the person has a relation that these sequences are going with my movement. So there is a logical relationship with the music and the body movement. So always use sensory feedback which is specific to the desired movement. Any non-sensory feedback is always useless. Non-specific sensory stimuli is always useless. So do not use coma stimulation program in abstract way. There has to be a relationship of the coma stimulation program. Like suppose you are using smell and taste. So you mobilize him and take him into the kitchen, or make him sit by the side of the dining table, and you arrange the plate, and then you give a smell of the some food he likes. Let us say you are giving a smell of pani puri or chaat. So we always remember typical pani puri smell and chaat smell, and the action which we'll be doing to eat the pani puri, like you are lifting the pani puri and opening his mouth and telling him to eat, although you are not putting the pani puri, but this sensory feedback has a relationship in real life, and this will make more sense than just giving a only smell of pani puri to the person. Like he's sleeping there, and you are putting smell of pani puri. He understands this is pani puri, but what am I supposed to do with that? Okay, so please understand these things very commonly in coma stimulation. Because in OS11 they have said that these are the sensory things you are supposed to do. So we always do all the sensory stimuli in isolation and without any overall meaning to that stimulation. Abstract meaning is not good. Abstract meaning can be good in long term, but initial phase you should have a realistic, real life situation, and all the sensations or all the sensory stimuli you are giving has to be relation with each other.
Very interesting. So actually, that made me stimulate also some think of some questions to ask you. So multi-sensory stimuli is always better than giving one single sensory stimuli. Sensory stimuli is always better than giving one.
Hello, Manasa, are you there?
Yes, sir.
Now, see, when you are saying multisensory, the word is not always multisensory stimuli is always better than single sensory stimuli. It depends on the task. If the task requires a lot of multisensory stimuli, then it is logical. If the task doesn't require multisensory stimuli, it is not important. Like suppose you are training somebody eating, and you put a lot of high-end music, which is at high beat, it is not logical. Okay, or he's eating and then you are tapping on his shoulder or this area. If that sensory stimuli is not required, then it is not required. But if you are teaching somebody dance or some fast move, then there is a there is a somatosensory feedback is also happening, there is a verbal feedback is also happening, there is a visual feedback is also happening, there is a music which is giving auditory stimuli. In partly, as you said, multisensory stimuli is better, but you should always remember what is the overall goal and is it required or is it desirable. If it is not desirable or it is not need of the task, then multisensory stimuli instead of helping will cause more damage. Let me give you an example. Like what happens, people, because we know that auditory stimuli is working, so the person is sleeping in a ICU and you put a lot of music in his head and it is his now sleeping time, man, and you are putting that headphones throughout the day, then that is not acceptable. And like if you are putting music there which is talking about high intensity music and you are giving a very slow sensory stimuli, oh how are you doing, you are so good. Now these two stimuli are not related. If a high intensity music stimuli and a slow touch is not related. So multisensory stimuli is good provided that task and that environment needs that multisensory stimuli.
So it should be an inherent part of the task. Like part of the task, you have to. Okay.
It has to be a part of the task. And if that task requires only one sensory stimuli, then use only one sensory stimuli.
Okay. Understood, sir. Thank you. We have another question. Sorry, one second. Yeah. How can we incorporate robotic training with real life task or goal?
Go again.
How can we incorporate robotic training with real life task or goal?
Sorry, I'm not able to relate with the question.
So she's asking, how can we use this robotic training in a realistic way? Means in a real life task, like maybe if she wants to do sit to stand or some other thing, then how can we do that?
See, understand what is robotics. Basically, it is the external device which has sometime artificial intelligence or it has some inherent properties which helps you to do something or not to do something. Like, let me give a simple example of non-artificial intelligence robot. Like if you are using a wedge and you are making him stand on the small wedge and you are shifting, the wedge itself gives little bit tilt. Right? The wedge doesn't have intelligence. There is no artificial intelligence, but it has inherent properties of tilting. So that is acting as external device to stimulate your activities. So if you really want to use robotics, the current robotics has added a lot of artificial intelligence component into that. You may not use that. You can use a very simple parameter mechanisms also can be done to stimulate the activity. So let me give another example. So if you can see this bottle here, I wanted to teach somebody to the forward flexion or want to move like this. So a simple device like I by this bottle, because this bottle has the inherent properties which can assist me into rolling. So this is the technical example. So the external properties of the robots can help you in assisting the device, like a robot used for flexion extension movement for the upper lip to reach out. So there are two arms in the robot which helps you to go forward and backward. So if anything which externally you put and assist his elbow flexion extension or forward movement, it is a technically called as a supported robots without artificial intelligence. Personally, I am not a big fan of robot, I don't think we should get dependent too much on robots. Only if your objective is to reduce the cost in terms of scaling business, then it is good. Or if you want to reduce the human efforts, then it is good. Or if you want to give more challenges, then it is good. Because robotics has a good variability, flexibility, and documentation better. But if as a therapist, if we could also do that, only if you are not scared of getting tired, or if you have a lot of manpower who can substitute the activity, then it is always better. Because being a human, you can do ongoing permutation, combination, and changes, which robots does the same activity. Robots are only good in the task and activity which are repetitive in nature. Always remember one word: any task which is repetitive in nature, robots are good. Any task which is cyclic in nature, understand, there is a repetition and there is cycle. One by one after cycle, another. Like walking is one cycle after another, is a typical cyclic in nature. Anything which is cyclic in nature is robot is good. Like robot can teach you flexion extension, but robot cannot teach you different types of variation for the upper limb. So lower limbs or simply walking robotics is much better because it's repetitive, cyclic in nature. Or when you want to reduce human effort, then also robots are good. So you need to decide which activity can be do the robotics. Like we take a non-physiotherapy example. You must have understood a concept called as automation. Like a lot of mechanical industries are going into automation, but not everything can be automated or everything cannot be motorized. Anything which is repetitive, same thing happening again, and there is a cyclic in nature, and there is chances of error, or there is chances of tiredness, and there is chances of these parameters affecting on the performance of the whole task, then robotics are good. Like imagine painting a car. There are a lot of instruments which paints the car repeatedly. So the robot can paint around hundreds of cars, but if you keep a man for painting 100 cars, probably will get tired. There is high chances of error. So like this, it is your choice that when you want to use robots. So I will repeat again: more repetitive activity, more cyclic activity, more organized activity, and if there is a chances of error more, and if there is chances of tiredness and affecting on the performance, then robots are good. But anything which has a lot of permutation combination should be required, then robotics are not good. Instead of that, the virtual reality environments, which are gaming environments, are much better than the robotics, because it has itself based on how do you perform, the virtual environment adapts to your performance, and it reacts to you better than the robotics. So I prefer virtual reality more than the robotics.
They're very interesting. So, can we combine virtual reality and robotics together?
Yes, if your objective for virtual reality, like with virtual reality, you can do whatever other thing which the robots are not doing. And if you want to reduce the human effort, you want to reduce the error, then you can use robot and then combine with the virtual reality, like the newer additions like exoskeletal types of robotics. And if you combine that into the virtual reality training, then it is very good. Now there is the virtual reality is going into the next level, is called as augmented virtual reality. Like you must have seen in Hollywood movies, usually we use the VRs on the head, and then we play in random. Now there is a augmented virtual reality, like you get a virtual reality here, and there is no screen, but you must have seen they touch on the screen and then it moves. So uh, if you have seen Tom Cruise Minority Report, and there are some new advanced technology like Iron Man. Iron Man uses the augmented virtual reality. So he does like this, then the screen gets zoomed in, zoom out, then he touches from here to here. So this is augmented virtual reality. So we are with augmented virtual reality with robotics. If we are able to do this permutation combination, then it is too good. And there are good equipments are nowadays they are developing for the hand training also, and hand range also, which are coming in the market. It is still not there, frequently been used. Like there is an instrument, there is a strip kept close to you, and you are working on the computer, so it picks your hand movements. And suppose I do this, so in the screen that will pull, suppose this is bottle which is virtually in the computer, and I do this here, so this will pull that. Or if this I wanted to open this, so I do the action here virtually, and in the screen that will open the bottle. So it picks up our kinetic movement and then adds into the real virtual reality type of environment. This type of activities are much better than just mechanically assisted robotics.
Yes, sir. So one thing you mentioned about virtual reality was that it allows us to have remote access to patients also, like for rehabilitation. When they are not with us, they can practice through virtual reality. So what is the safety considerations for that we should keep in mind? Because now there is no supervised physiotherapist out there.
See, in virtual reality environment, there are only two common type of safety measures should be taken. No falls. If you use, like I use harness whenever I am giving virtual reality in standing, I use a harness. And if you prevent the fall, that is one of the safety thing. And second thing, while he is moving, what is the chances of he is getting injured? No patient will not do too much of hyper movement except the patient with ataxia and choreoarthroid movement. All other patients, they do virtual reality training very safely except the chances of fall. So you can do the distance training by virtual reality by prevent the fall. So if you want to prevent the fall, use a harness. And for chances of injury, make sure that the environment is cleared while he is doing activity. Anyways, the all virtual reality systems or the cameras, they always advise you to remove all the things in the path of the camera, because it will obliterate the mechanism of virtual reality. So indirectly, the virtual reality environment already takes care of that. Only you have to take care of the fall.
Okay, sir. Thank you so much. I think we are done with the questions for today. There are
I
no
can
more
see a lot
questions.
of question on the YouTube. No, so
Yes,
hold
I have.
on. There are a lot of questions.
So it's actually feedback regarding the lecture, the questions I have picked up.
Okay, okay, then that's okay. So, so we can conclude today's session. The neuroplasticity series is over today, and from next week we might start with lectures on spinal cord injury. Usually, all books and a lot of people who talk on spinal cord injury, they talk about how to manage a complete cord injury, and they talk about how to rehabilitate a person with injury with the available control. Suppose he's got D6 level of injury, so what are the upper limb and lower limb question? That is how we rehabilitate them in the real life. What I am going to discuss in future is that how do we uh, uh, train a complete cord injury towards the incomplete cord injury, and how do we try to get the recovery out of the complete cord injury, and what are the factors which can affect the complete to incomplete journey, and what are the points can be considered during that will be discussed in future lecture. So if somebody is interested more in learning how to convert a complete cord to an incomplete cord, or how do we understand it is doing a good transition or not transition, what kind of exercise design and prescription of orthosis should be taken care during this complete to incomplete transition. Let me take this opportunity. This was one of my um, dream project to write a book on complete to incomplete cord injury rehabilitation, because a lot of books are there on complete cord injury, but there are very few books on how to do the rehabilitation in incomplete cord injury, or how to stimulate rehab from complete to incomplete cord injuries. And this assumption I have take based on that not all complete cord injury are complete. And I have written a blog also on this, that on initial assessment everybody shows complete cord injury, like everybody has no law control below the level of injury, and we assume that it is complete cord injury. So my suggestion and my advice is that never think every cord as a complete. I assume every cord which is showing complete injury as an incomplete injury. I treat that for a few months, and based on the recovery, then I come to conclusion if it is complete or incomplete, and what is the prognosis in that patient. So averagely, I treat the patient for 6 months to 2 years, and after that, then I try to conclude if it is complete cord injury or incomplete cord injury. Because in the beginning, everybody shows the signs of complete on first evaluation or first 1 month evaluation. Everybody is complete, and statistics shows that all the complete cord injury, out of that 10% chance that all complete can be converted into incomplete. So thank you very much. This is the end of the today's lecture.
Yes.
Shall I close?
Yes, sir.
Thank you.